last time. Awesome. Great. Hello, everyone. Good morning, good evening, where you are. Welcome to this session. I will share my slides and just please confirm if you can see the slides, and I will take it from there. Can you see my slides?
I can see them, yes.
Yeah. Awesome. Right. Okay. So I'm the Vice Chair for International Stillbirth Alliance, and I work with a Public Health Foundation of India based in New Delhi, and with Institute for Health Metrics and Evaluation at University of Washington based in Seattle, US. The context of the presentation today is, we talk a fair bit about stillbirth estimates, stillbirth numbers, global estimates, country estimates. So this presentation is going to highlight what are the actual issues with availability, and are these data adequate, and what is the quality of these data that we look at, and what are the issues that we need to address. So more of a practical presentation on what the issues are with the data that we all use and monitor stillbirth prevention around the world. These are the two, currently the big estimates that we see for stillbirths, stillbirth numbers and stillbirth rates. One of these is the UNICEF IGMI report, which all of us are very familiar with. And it's being updated, and we probably would have the next update early part of next year. And the other one is from Global Burden of Disease study. These are the two main ones that are available for us to use. The UN IGMI one estimates for 28 weeks gestation definition, and the GBD one estimates for 28 weeks, 20 weeks, and 22 weeks of gestation. So there's a bit of a difference in what's estimated in terms of definition, but these two estimate the stillbirth rates that all of us are familiar with. So as I said, I will go behind what the estimates are and what are the data behind these estimates and issues with it. In terms of counting stillbirths and also in terms of classification of stillbirths. I'll start with counting. So the estimates, irrespective of the report or the study that you look at, the estimates that all of us are familiar with are mostly modeled global estimates and modeled country estimates for majority of the countries. So what I have here comes from the UN IGMI report. And if you look at the data given in of the 195 countries for which the report generates stillbirth estimates, 22 countries actually have no stillbirth data, and 38 countries lack quality stillbirth data. So they have some, but it lacks quality. Right. So basically, the estimates for these countries are more or less driven by the models, covariates. I will not get into those details today, but just to highlight that, a proportion of countries are either missing data or the data available is of poor quality. But the important part is that these countries where data is poor or missing, most of them are actually from low and middle income countries, where we know the high burden of stillbirths is. And about 1/3 of them are in sub-Saharan Africa, which again is where the high burden is. So the implications of missing data or poor quality data is immense when you look at these estimates. And this is why when you look at these, when you read these estimates, the 95% CI or the uncertainty interval around each estimate is wide. So the wider the estimate, less confidence that you have in those estimates. So it's important for us to know, and that is because the data coming at the back end are poor or missing. I have a few global maps from the recent GBD estimates for stillbirths, which will be published about in a month, just to show the availability of data that we talk about. This is the data availability for stillbirths based on vital registration. So the more green it is, the more data availability is there. And as expected, you see it's more green in high-income countries. India is, sorry, I think there's someone.
Right, drop to the top.
As I recall, in back of the computer, there's like.
Nancy, can you please mute? Thank you. India here, I will talk about it later. India is fairly green, but most of this data doesn't get used, and I will get into those details a bit later. Because this is just data availability, not quality map. There are countries where vital registration is poor, surveys are undertaken, and many of these are low and middle income countries, and majority of the surveys that you see here are DHS, the Demographic Health Survey. So the more green they are, of course, more availability, but as you see, most of this is Africa here is gray, all of this is light blue, and so the survey availability is also poor. And the countries with vital registration, good vital registration, will not have these surveys. So, for example, US, Australia, that is why they are gray. They don't need these surveys because their vital registration system works. And then this is the data availability based on scientific literature. So it's the research like people like you and me do and publish. This is the availability of that scientific literature on stillbirth numbers, estimates, epidemiology that gets picked up as part of GBD. So there's a fair bit of variation, but as you can see, the data availability is actually not that great. This map is the latest map from UNIGMI report, which is basically documenting stillbirth rates. So the more red it is, higher the rate. And as expected, you know where more red and orange is. In terms of numbers, there are 6 countries where stillbirths are concentrated: India, Pakistan, Nigeria, Congo, Ethiopia, and Bangladesh. In fact, if you put India, Pakistan, and Nigeria together, that accounts for 1/3 of all the burden of stillbirths. And I'll take example of India, Pakistan, and Nigeria to show what kind of data are available and go within these models. This is for Nigeria. So this is the years of data availability from 2000 to 2018. And these points that you see are the points that show that data are available. Some data are available for this country in this year. So you see these points. And this is the line is the actual estimate. So you can see Nigeria, which has got one of the highest numbers, actually has only minimal data points. And these data points are way below the actual estimate. And it's actually, these points are excluded. So when you see this tick, that means this data are available, but data were excluded, which means that they were not of enough quality for them to be used. This is a slide showing Pakistan with the data sources that got included. And so you see the data sources got included, and this is the estimated modeled line. And if you change this to also include data sources that got excluded, you see how concentrated the map is. So there's much more data available, but the quality of data did not make it to these estimates. So one is availability, and then being available and being of good quality for those to be used. So you see there's a fair bit more of data available in Pakistan. Now let's look at India. So these are the data sources that were included for India, and it looks like you have a fair bit, which is great. And when you include the excluded data sources, you again see there's much more data available, but clearly does not make it to these estimates because of various reasons, predominantly quality. I will take a deeper look for what happens in India to kind of highlight what the issues are with different types of data sources. This is a list of data sources from UNIGMI, what all was available for them to use. But what's important is these ones here, surveys with reproductive calendar, HMIS, which all of us talk about a fair bit, that HMIS needs to improve to capture stillbirths, and vital registration. These ones actually did not make it to the estimates because of the quality issues, but predominantly population-based surveys, standalone research surveys actually made it to these estimates. So clearly there's difference between quality of what is done as part of research and as part of routine data collection. And as I said, I will take you through some examples of data sources for India to highlight what goes on behind these numbers. We'll go through 4 types of data sources. I'll start with vital registration system, which is basically a system where, each country has its system to keep track of the number of people who are born and the number of people who die. As simply put, by age, sex, time of day and time. So in India, stillbirth registration is actually compulsory.
Thank you.
It's been. Chantal, can you please mute yourself?
Could everyone mute themselves, please, when they're not speaking? Thank you.
So it's been compulsory for a long time, which is great since the beginning, actually. But this is how it looks. This is the percent of registered stillbirths in vital registration system that we have. This is extrapolation to the total number of stillbirths that we would have had in that year, and the number actually that are in vital registration. So as you can see, the number of stillbirths that get into the vital registration system is really low. We took a deeper dive into one of the states, Bihar, which is up north here, which is one of the highest numbers of stillbirths and neonatal deaths in the country, so high burden state. We took a deeper dive to see why these babies are not registered at population level. So we had 8,000, close to 9,000 births in a population sample of about 300,000 people. Of the 121 stillbirths that we identified, only 2 were registered. So they had a stillbirth registration certificate. And the reasons for not registering stillborn baby are not new to anyone who's on this call. Basic reason is the baby was born dead. There's no need to register, and didn't really think about registering, getting a certificate for a baby that was born dead. That's also because, a lot of the registration for birth is linked with schooling in India. So the assumption is that if the baby is dead, obviously there is no requirement for schooling, so you really don't need that certificate. So birth certificate is what people understand, but still birth certificate is more or less unheard of. This was one aspect, looking at the population. We said, okay, but many of these babies are now born in institutions, right? Facility deliveries. And it's mandated for the facility deliveries to be registered as part of vital registration system. So we took a deep dive into health facilities in the state, and we identified 6,000 stillbirths in these facilities over 2 years in 58 facilities. Not even one of the stillbirths were notified by the facility to the vital registration system. We again did qualitative interviews with the staff who were responsible to upload the data to vital registration system. The reasons were the same. The same community reasons is what we found here. We didn't really find reason to enter data of a stillborn baby. And many of them said that no one came asking for a certificate, so we never uploaded the information to vital registration system. And interestingly, no supervisor for vital registration or within the health system ever asked about these babies. So these babies were basically lost within the system, and they were really not counted or their information uploaded to the vital registration system. So this is why the vital registration system, even though has the mandate to record stillbirths, to issue stillbirth certificate, the data availability with vital registration remains poor because of these issues. In fact, I think if I remember in the UN IGMI report, of the 105 countries that had vital registration data available on stillbirths, I think 70% of the data was included, 70% countries were included, and 30% could not be included as part of the model estimates. So if I extrapolate this to Bihar, of 3 million births in the state, we would have about 42,000 stillbirths, and only 850 of them would have been registered and counted. So clearly you see the gap in terms of, the numbers actually of these babies, and the babies that counted is fairly huge for us to, actually count them well and to make a difference. Unfortunately, we did a similar exercise in one of the largest states, which is called the largest burden in India. And in fact, we say that if the burden in this state changes, a lot of global numbers will change. So it's that huge. Look at the number of stillbirths here. We found similar issues in community, and we found similar issues in the health facilities. So clearly, the data are available, but the data are not getting transported or updated or uploaded to the right facility, right system to get counted. The other system that India follows is called sample registration system, which is a bit unique to India. And that's because we really do not have a good cause of death system in the country. So there's a survey that happens for a set population sample. So there are people who are, continuously monitoring a set of population. And related to stillbirths, they monitor every pregnancy outcome in that given population. So there's a person responsible for a door-to-door survey to make sure he knows who is pregnant and follow that pregnant women to identify the outcome of that pregnancy. And there's a fair bit of monthly checking and half-yearly checking that's built into the system. So we looked at, and because they're doing pregnancy outcomes, so we compared what SRS tells us about neonatal mortality, because all of us know neonatal mortality is being taken care of or is on the agenda of the governments, and stillbirth is not. So we looked at what is the SRS estimate for neonatal mortality by state and compared that with GBD. And if you look at the maps, they're fairly similar. There's hardly any difference between what SRS is telling about neonatal mortality rate and GBD, which is a moderate estimate. But when you look at stillbirth, the maps are very different. And then you wonder why. Because then you get into the details and you wonder why, if someone is bound to check every pregnant woman in a given population and follow her through her pregnancy, the neonatal death gets recorded, but I'm sure that this person would have also figured out that there was a stillborn baby, but the stillborn baby doesn't get recorded. So we dug a bit deep into the training manuals and had conversations, and we published this. There's hardly any indication of, what to do with stillborn babies. It's not supervised, it's not asked for. So again, similar issues to what we found in the health system. So dead babies are not important, but a baby born live who dies is important to get counted. So clearly there is a mindset issue of, that stillborn babies are not important to count. So again, SRS really does not get used. In fact, if you look at the stillbirth rate in SRS, that's about 4 per 1,000 births, which is much lower than the actual estimate, which is anywhere between 13 to 15 stillbirths per 1,000 births in India. So there's a fair bit of difference between what gets reported in SRS versus what the reality is. So again, data is available, but cannot be used because it's poor quality. The other one is HMIS. Many of us are familiar with this. And I'm just thinking of the HMIS with the new NIGMI report. I think 55 countries had HMIS data on stillbirths, but only 30% of that data actually got included. So major issues with HMIS data clearly. This is from the 2 states that I talked about. This is the rates that we calculated for neonatal mortality and stillbirths in the facilities for these 2 years. And this is pretty interesting. You look at the SBR, the stillbirth rate in the health facilities is much, much higher than neonatal mortality rate. It just doesn't make sense, right? That's not possible. This much difference is really not possible. And then you deep dive into like what's actually happening here. So we again did a deep dive here. I will, cut it short, but the basic summary was that because there is push to do death reviews, both maternal and newborn death reviews, and actually perinatal death reviews, where stillbirths has to be also, the audit has to take place, but it really doesn't. The audit system is very punitive in the sense that if there's a newborn death, it's punitive for the health providers that were responsible for that delivery. So the easier way to deal with that punitive action is to show that the baby was born dead. So the early neonatal deaths are actually represented as stillbirths in the HMIS, because then there's no punitive action, because if the baby is born dead, there's nothing you could do to save the baby, is the kind of concept that that gets carried around. So again, the question here is, it's punitive because it's individual accountability, health provider accountability, but we have to reach a stage where it needs to be systems accountability for these numbers to be counted right for the action to take place. The last one here is demographic health survey, which again, many of us who work within low and middle income settings are fairly, aware of. There are until recently, so it's changed now. Until recently, the rounds of DHS were really not capturing the universe of stillbirth. But that's now changed in the recent round, so which is a good sign of population-based counting of stillbirths is going to get better as part of DHS. We're looking forward to the data that comes in from the next rounds. Then a bit on classification. So classification of stillbirths is also important. You need to know how many of them are intrapartum and antepartum to take action. And we know that, intrapartum are preventable. So this is a UNIGMI recent report where 2 and 5 stillbirths were estimated to take place during labor. Again, I will just highlight on a few slides what are the issues with classification at the ground level. These data directly come from the death registers that are kept in labor rooms or delivery rooms in these health facilities that we sampled in the 2 states. And this is how it's written. Macerated, intrauterine death. The other one had intrauterine death, stillbirth, macerated, stillbirth fresh, stillbirth postterm. So there's different ways of how stillbirth got recorded within the death registers. And this is the only recording that's available for most part within the health systems. And because the review doesn't happen, we really do not have much sense of the actually timing of stillbirth, because the clinical data that's available in health records is actually very poor. So it doesn't allow us to understand clinically whether the stillbirth was antepartum or intrapartum. So also then again, a fair bit of information on this classification is attempted as part of surveys, which is basically self-report by the mothers. And there are issues with that. We published this as well in PLOS Medicine. So basically, typically in surveys, you end up asking, when did the mother feel baby moving last prior to delivery? And then you also ask the appearance of the baby at the time of delivery. And this is an example here. So and there's science behind this research to say why the cutoff is 8 hours. I will not get into that. But the assumption is that if the mother felt the baby move within 8 hours of labor delivery, you expect that to be intrapartum. And if it is 8 hours or more, you expect it to be antepartum. But then you also ask the mother about the appearance. Now you would expect intrapartum to look more fresh and antepartum to look more macerated. But again, if I just use the last movement definition, by that definition, about half of them would be antepartum and 46% would be intrapartum. But if I give more weightage to what the women said about appearance, the classification would actually change and change a fair bit. So there are clearly issues in terms of how we classify, or the data that is available to classify the type of stillbirth based on self-report by women. And we rely on this because clinical data is actually very poor. So what does all of this mean? We know that at least 56 countries will not achieve the target by stillbirth target by 2030. This was in the UN-IGME report. And for us to make sure that we understand the targets, for us to kind of make sure that we are able to monitor the change in stillbirth over time, we need to actually make investments in improving the data documentation. Because at some point, we hope, I think all of us in this room today hope, at some point we would be at a stage where most of the data that is available for stillbirth is actually not modeled data, but is data directly available from the countries as part of different data sources. It's available and it is of decent quality for us to use it for monitoring and taking action. This is what I've summarized. So basically, we do need investment in relevant research and interventions, maybe implementation research, to understand how do we actually work towards improving these statistics so that we are less dependent on these modeling to monitor stillbirth rate over time, especially in high burden settings where the numbers are higher and the data is poorer. These are some of the relevant publications from us that I have, quoted as part of the presentation. And some acknowledgements here for the team, and this work was funded by Bill and Melinda Gates Foundation.
Maybe going to.
Right. Thank you for your time, Paula. I hope I've kept to the time.
Yeah, he's heard that he has to
kept
go. But he's heard
right
nothing
to the
about
time.
Perfect.
Zoom
Thanks.
or,
Somebody's nothing there. I can't
if
see
he
who it
only
is.
has to be there 3 days, or if he has to be like we need to know something.
So, can everybody
So,
please mute if you're not?
What I'm thinking is you're
speaking,
probably
please?
gonna have to do it tomorrow. Because he's like, if I hear back today or tomorrow that I will be doing it over Zoom, can we change it back?
I don't know if I
And
can
I'm
mute
like,
people. I don't think I have that. Melissa, can
Yeah.
you please mute yourself?
yeah. Well, yeah, he probably should have, especially because he's not working tomorrow.
Oh, I can mute actually. Sorry, go ahead.
You can mute, right? Okay,
Yes,
brilliant.
I've managed. Yes.
Okay, brilliant. Thank you, Raki. Yes, you're perfectly within time. Great, really interesting. Right, open for questions. Please, any reactions, thoughts? Similar where you are, different where you are? Comments in the chat. And Raki, if you want to stop sharing for a minute, then we can see more faces. And
I have a question,
Bharti's-
Raki, but I
Oh.
might have missed out that data. What is the percentage of stillbirth? Do you have a percentage, or there's too many that are not accounted for, so you don't know? Like in Canada, we say 1% of the births are stillbirth. Do you have that kind of information for the 3 countries you mentioned? Or they're not well taken care of, so you can't really estimate?
A very good question. I'm sure there are those estimates available, but I don't know at the top of my head. And I'm just thinking India specifically. it would be very difficult for me to answer that question because it would vary so much by the states that we're talking about and by the data source that we're talking about. For example, for one of the India slides, I showed that the vital registration system, we should typically capture everything. There's underreport anywhere between 40 to 60%, right? Depending on which year and state that you look at. A good question, but there's so much variation by state or by country and data source here.
Just as an information, in Quebec and Canada, we don't have data on miscarriages. Every pregnancy lost before 20 weeks, we don't have data. So at one point, I estimated, since we say that there's 15 to 20% of pregnancies that end in miscarriage, I estimated that there was approximately 20,000 miscarriage in Quebec. The funny thing is 5 years later, everybody is saying that as if it's a real data. Even the government, they cite there's 20,000 miscarriage. And I feel like telling them we don't really know.
We
But
don't really know. Yeah, you're
we
right.
don't really know. But it's become like, okay, that's what we have because I just made an estimate.
Yeah.
So
Yeah.
So
And
I understand the lack of data. Yeah.
And you raised a very important point, Francine. I just want to highlight, just extrapolating that, that the estimates that we're talking about are still, 28 weeks or more. But, and in the countries where late gestation, right? Your ICD, your actual definition is 22 weeks, right? So the other thing is, we are so struggling with 28 weeks and the availability and quality is so poor. Imagine if these countries have to go all the way back to the actual definition. The data, and I think GBD estimates have recently done that, but the problems are even more. So it's so difficult to answer your question. You're right. It's very difficult to know the extent of underestimation. Thank you. Olga.
Thank you so much, Raki, for this presentation. This is absolutely what I love about, looking at stillbirth data because there's so many issues with the quality. And as you highlighted, data are being collected. There are systems in place. And what you highlighted so nicely was the systems are clearly not functioning appropriately. The quality of data is not good. So is that a process issue? Is that a human resource issue? And the other thing that you highlighted is how the supervisors, for example, are not being asked for the data. Excellent point. People, when you're filling out forms and no one's checking whether they're filled out correctly or not, that's going to matter. And so highlighting that component is really critical. Gosh, I had one other point to say, and I don't remember it anymore. Oh, well, I do wonder with ICD-11, with the transition to ICD-11 and the recommendations that are coming out, sort of standardizing the approach to stillbirth reporting, if there's an opportunity there to, transition to establishing a standard. And even within the WHO tools that they've developed, there's inconsistencies where I think recently the publication that came out, Hannah and others presenting on, stillbirth should be reported by weight in grams. Well, if you look at DHIS2, if you look at Doris and whatnot, you do not have that. And so, we're coming out with recommendations, but the tools that are that have been developed to support the reporting do not align with the recommendation. So I do think I'm hopeful that with ICD-11, even though that it will take time to implement, there's an opportunity to align all the standards for improved reporting. But again, even if we have the systems in place, if stakeholders are not asking for the data, then we're not going to have that accountability. We're not going to have that investment in reporting. So there's a lot that needs to happen. And I think that you highlighted some really critical data quality issues so nicely. So I'm hopeful that we can move in the right direction. So thanks so much for this presentation.
Thank you, Olga, and totally agree with all that you said. And just to highlight a bit more on the birth weight, that given that is part of the definition and recommendations. So as you said, DHS data, and I'm talking about India here specifically, and that would be same for many of the African countries. Even for neonatal deaths, I'm starting with neonatal deaths. Many of the early neonatal deaths actually have no birth weight taken. So, and in our population surveys in the 2 states in Bihar, most of the stillbirths had no birth weight taken at all. And when you look at these estimates, what goes in, a lot of it is still based on gestation, and the birth weight is actually very, very minimal. So you're very right, you have recommendations at one hand, but the actual practicality of getting it done, the process of making it happen is where we are lacking. And that's something that no one is investing in at this point, at least. Totally agree. Thank you.
Raki, there's one question from Bharti in the chat. That is, can you recommend which type of database would work best for a country like India?
Ideally, vital registration system should be the way to go, Bharti. And the system has put enough effort to make sure that all facility deliveries get documented. And thankfully, most of the deliveries in India right now are at facility, right? But as I showed in my slides, that process hasn't really taken place at the health facility. So you really don't have to wait for people to go and get a stillbirth certificate to count that stillbirth. If the facility is able to upload that data to the vital registration system as they're meant to be, we would have better sense of stillbirth in the country tomorrow, if things change. So that's the ideal way to go at this stage, Bharti.
Thank you. Thank you.
Maybe if this, I can see people from, Africa, if anyone wants to add, given that, I've kind of talked about issues in India, I'm sure many of them are similar in Africa, and data availability quality issues are similar. But if anyone wants to add something for the group, that would be great. If you want to add your experience of what's happening in your country. Maybe Linda was here. Linda, do you want to add anything?
Hello. I can't find this thing. This is Tamkeen here. How to raise my hand? I can't just figure it out somehow.
That's fine,
Yeah.
Tamkeen. We
No,
can
but
hear
we
you.
can
Go
hear
ahead.
you. We can hear you. Go ahead.
I was just wondering, for India, we are already collecting so much data. There's a system which is recording all antenatal women. And then there's a system where we are paying the women through the JSSK. So it has to be recorded to be able to give them the money. So somehow, if there's so much duplication of collection of data, and there's so much, everybody's overworked. And the main reason people say that they are not able to record is overwork. So instead of doing, collecting data at multiple places, we already have a system in place for that JSSK. Why we can't utilize it or extract some data from that? At least we can get the numbers.
Yep.
Just looking at the JSSK data. If not the causes, then at least the numbers.
Yes. You raise a very interesting point, Tamkeen. So, vital registration is, of course, the best way to go. One of the recommendations that we made to the UP government after our work was, that you give the money to you give the incentive to the health worker for each delivery after the health worker has filed whether the baby was born alive, if the baby is currently alive, or if the baby was stillborn. Do not give the incentive for each case to the health worker unless that information is complete. And that's actually made some difference in UP. In fact, and because we said there was a backlog, if you look at UP death and birth registration, it just went up in 1 year and came down because a lot of backlog got entered. So totally agree with you. So there could be ways to make sure that the health workers who are meant to record this data are kind of forced to record this data if it's linked to their timing of incentive. Totally agree with that. I was just going to say one more thing of what you said, but I've kind of lost my train of thought there. But thank you for raising that. Yes.
Thank you.
Sorry, what I was going to say was this is, we're talking only about stillbirths, but we work across all ages. What was very interesting to see was the information on deaths was more complete with the pensions department than with vital registration, which is, you think about it, it makes logical sense, but they haven't thought of, combining the information from the two with unique ID of the person who's dead, and your vital registration system data would be so updated. But the pension department had more updated data on deaths than the department that should actually have it.
So interesting, observation.
And if I can just follow on that, I think, Raki, you highlighted a point. There's value in the pension system. There's money behind identifying whether somebody dies. And that's exactly what you pointed out with stillbirth registration, how birth registration is linked to school enrollment. So if a baby is born still, then there's no value in registration because of that link. So, there's the carrot and the stick approach. You want to incentivize registration, you want to incentivize this reporting. And so you link it with pension, you link with birth registration in schools and whatnot. But with stillbirth, it's very difficult. And so presenting the value of this data for policies for prevention of other families is so critical. And it's really trying to advocate to so many different audiences for families, because oftentimes the burden is on them to register, healthcare workers to recognize that they're not going to be punished, or they shouldn't be punished for reporting this, but also for policymakers, because they can benefit from this information and to value it. So it's really, I think that's the challenge with stillbirth advocacy. There's so many audiences, and we really have to educate them all to ensure that there is improved reporting and action on stillbirth.
Totally agree. And Olga, that's why, fortunately, because many of the deliveries are at facilities, and if the facilities are mandated to update that information irrespective of the outcome, the numbers would change. So then we really don't have to think of incentivizing the community for stillbirth registration. So the onus would be on the system. And if 90% of the deliveries are in the facility, you're actually counting way more than what you're counting now in any case. And so the system actually is designed for that. But it's the community mindset of the health workers that there's no point registering a dead baby, and that's what needs to change. Yep, all right.
Mamadou, any comments from Africa?
So there's a comment, there's a question in
Hello?
the chat box about,
Hello?
you know, yes, and I think what we're talking about is, yes, the culture plays a role
Good
in
morning.
yes, sorry, go ahead.
I think that someone is asking me if I come from Africa. Hello?
Mamadou, I know you come from Africa. We were wondering if you
Yes.
had any comments from the Africa perspective.
Okay, thank you, thank you. Exactly, I am Mamadou. I come from Mali. I am yes, I say member since 2017, if I remember. Okay.
Thanks, Mamadou. Yeah. Any comments about stillbirth data from your side in Mali?
Any comment for stillbirth? Okay. From stillbirth, I did my PhD thesis on stillbirth in Mali since 2021. I finished my thesis, my PhD. Now we are working on civil registration of stillbirth, of perinatal death, and birth in 4 districts in Mali. At last meeting, I said that we have a protocol to implement the regions of stillbirth in 4 hospitals. I have written this protocol with Mr. Harvey. I don't know if Harvey is now in this meeting. Harvey is a obstetrician in the United States of America, exactly in Yale University, since 2022. But we didn't have a fund to implement our project. It was my last conversation at the last meeting.
Thank you. Paula, if I could answer a few questions in the chat, I'd probably start
go
from
ahead,
bottom.
yeah.
So, Jessica, thank you. I just want to clarify that we do not have incentives only to record stillbirths. So the incentive that I was talking about with Tamkeen is that the incentive is given for delivery at an institute in India, institutional delivery, and some part of it goes to the health worker who kind of makes sure that the mother delivers at the facility. So what we were talking about is that if that incentive could be given to the health worker after making sure that the pregnancy outcome is recorded, which includes stillbirth, live birth, alive, still alive, neonatal death. So that's what we were talking about. The strategy that India has put in place to document all pregnancy outcomes is what I said, that the health facilities have been linked directly with the vital registration system to input that data irrespective of the outcome. But that's not working well for stillbirths because people who are managing that system don't think it's important to document stillbirths because the baby was born dead. Okay, there's a new comment. A WHO VA tool is actually fairly simple to use in software. I can't do that right now, but it's very easy to use. But I think that's conversation to be held elsewhere. Okay, I think my comments have meshed up a little bit. Is there something that I have missed? Yes,
Sue had
yes.
one about culture.
Yeah, the cultures. I think that's what we've been talking about. The culture, how you think of stillborn baby is what matters. And few years ago, we'd written a piece in BMJ Global Health about or let's simply put it, I think what we've said is that if you keep on calling them babies who are born dead, possibly nothing would change. But if we could start giving the notion that some of them, anywhere between 40 to 60% of them, should have been born alive, is the way to look at it. To start talking about, prevention. There's a hand up, please go ahead.
Thank you. I'm Elias from Ethiopia, and we met before, and student doing PhD on MPDSR under the supervision of Vicky Flannery. She was
That's right.
co-chair
Yes.
of ISA,
Yeah.
obviously, remember here, and presented my plan in 2023. Regarding to stillbirths, we have special interest in here with Vicky. She is leading the one of Center of Excellence in Stillbirth Research in Australia, and based at University of Queensland. So I was doing data collection for my PhD in the couple of 3 months is over in Ethiopia, and what I've learned is like days itself is something like they don't want to report in most cases. I was focusing on maternal and the perinatal days, surveillance and how it is working and what are the challenges. And even it is highly, highly politically sensitive. So most of the thing is like the reporting system is really very poor. And I was looking at over 10 years of maternal days through the MPDSR, and I was comparing like neonatal, perinatal with maternal, and most of the focus is around the maternal, as I've tried to interview individuals working on the area, in the hospitals, as well as down from the facility to the ministry level. So it is like very hard to get stillbirth data. And I've been doing similar studies like 8 years, 6 years before in the community. And what I've learned there is as well, even notifying pregnancy in rural areas like taken as a taboo, and nobody's like want to like report as she's pregnant or not, and then after some months it becomes like evident that. And then most of the days, what I'm trying to make is like starting from the community to the app. There are a lot of things in the reporting system, and the data is having of so many issues. And one of the area is like it is politically very sensitive, and I think that comes to maybe that the other issue that should take this fair actually in the future. Thank you.
Thank you. Thank you. Paula, over to you.
Great. Yeah. We just got 5 minutes left. Sorry, I lost the connection for a second there, so I cut out for a minute. Just checking if there's anything else in the chat. Don't think so.
Linda has a hand up.
Sorry, you can see my internet's a bit unstable. I just dropped off again.
Linda has a hand up, Paula.
Linda, go for it. Yeah.
Yeah, thank you very much, Raki. Thank you, everyone. Just to appreciate this presentation, that it's really necessary for us to show the figures so that they would know. Teaching the medical doctors who are doing their membership, I, for the first time, introduced a topic on stillbirth in their curriculum, just for them to know that we are talking about maternal mortality, auditing them and everything, but stillbirth is also a key issue. In Ghana, we have those that are recorded, we have about 9,000 every year, and that is a huge number. Yesterday, as I said, I had the opportunity to talk to the Nursing and Midwifery Council, and this is something that I brought up, that we need to be looking at those figures, not just as a number, but to look at them to use to do what we can do to prevent it. And Ghana, about 40% of the stillbirths also occur intrapartum. Just as you said, 2 out of 5 occur intrapartum. So that is a huge number. And I think that globally, this is one of the things that we have to bring out, that women go into labor and lose their babies, even those that lose them before they enter labor, a lot can still be done. So I appreciate this presentation very much. Thank you so much.
Thank you, Linda. Thank you.
Thanks, Linda. Yeah. Great. Well, we're just coming up time then. Great. Thank you so much, Raki. That was an excellent presentation. One more comment has come in. For prevention, we have to look for maternal, fetal, and placental causes. Most of the cases are due to placental malperfusion. Yeah, there's a lot of work on that. And I think somebody mentioned Harvey is one of our members who does a lot of work on this. And we've had quite a few presentations in previous ISA conferences about placental issues. It's certainly a big issue. But I think, you know, depending on the context, of course, there are many reasons behind that and many factors that contribute to placental malperfusion and other causes of stillbirth. So important to get the data and investigate as much as possible and yeah, look for causes for all those preventable ones. But it's very often a big combination of causes, as we know.
Yep.
So great. Thank you, Raki, especially, you know, highlighting that the really interesting case of India, which is a super fascinating subcontinent.
Yeah. Well, thank you. I really enjoyed the discussion. So thank you for all those who contributed. There's always learning. So thank you for that.
Great. So we should be sending around the presentation and the recording, and it'll be up on our website shortly. So thanks again for everybody for taking the time to join us. We really appreciate your interest and your support to ISA, and hopefully seeing you lots of you soon in Colombo and at the next ISA meeting.
Thank you. Thank you, everyone.
Thank you. Bye-bye.
Bye.
Thank you.
Thank you.
Bye.
Thank you. Bye.
Thank you.